today. I just wanted to say thank you so much to everyone for coming to this webinar on supporting young people with obsessive compulsive disorder or OCD. We look forward to speaking with you about sort of what OCD looks like in children's, teens, and young adults. We'll cover how to recognize the symptoms and learn some strategies for effective treatment. As a reminder, this was in the webinar description, but this webinar is being recorded and we will send a copy of the recording to everyone who registered. So if you weren't able to make this and are watching it as a recording, thank you for watching. And if you're here now, you will get a copy of this via email afterward. So with that, I'm excited to introduce Dr. Taylor Wilmer, who will introduce herself, but we are so fortunate to have her sharing some of her insights today. And I'll hand it off to you to kick off the presentation. Thank you so much.
Awesome. Thank you, Haley. So like Haley said, we're going to be talking today about obsessive compulsive disorder in children, teens, and young adults. And just to introduce myself quickly, my name is Taylor Wilmer. I am a board certified clinical psychologist who specializes in providing cognitive behavioral therapy or CBT and exposure-based therapies for kids, teens, and adults and parents with anxiety and OCD. And I have prior experience working in intensive and outpatient programs, and I'm currently the director of clinical product here at InStride Health. And InStride Health is a specialty outpatient provider for pediatric anxiety and OCD. And I'll talk a little bit more about our program as we go through this presentation. A couple quick housekeeping notes. All attendees are on mute, and if you have any questions, we certainly welcome questions, and you can submit those through the Q&A box at the bottom of your screen. And I'll do my best to wrap up about 10 minutes early so that we have some time for a live Q&A at the end. To give you a quick overview of where we're going, after this introduction, I'll talk a little bit about recognizing OCD in youth. So what is OCD and how to spot the signs and symptoms, and then talking about how OCD is treated in young people, and then talking about how to find help at InStride and our program that we offer here. As a quick reminder, this webinar is specifically geared towards providers and clinicians who support children with behavioral health needs, which can be pediatricians, psychiatrists, psychologists, social workers, psychiatric nurse practitioners, licensed mental health counselors, and other clinicians, as well as school counselors and school personnel who support kids and teens. So this is going to be a provider-focused webinar, but we will, if you're a parent or a young person who experiences OCD, there'll still be a lot of information in this webinar that's relevant for you, so feel free to stick around, but also know that we'll have a parent and caregiver-facing webinar happening in a couple of weeks on Tuesday, March 11th. And information about that can be found on our website and on our social media accounts, Facebook, Instagram, and LinkedIn. So I want to start by just acknowledging that OCD has a big impact on young people, and that's why we think it's a really important issue to address and to be able to provide effective treatment for. So just to start with a little bit of data and numbers, OCD affects 1 to 2% of young people ages 18 and younger. So it's something that is relatively common among young people, and oftentimes it develops at a young age. It can develop as young as 5, and there have been some cases reported even younger, but more than 20% of OCD cases develop by age 10, and many more will develop before age 18. So it's not only prevalent in young people, but also can start at a young age. Although I will note that sometimes the symptoms might sort of be unobservable or simmer under the surface until they become so big and so impactful that other people start to see them or recognize them. So sometimes it can be happening for a long time before others are aware that it's happening, and it may not become obvious until it's really, really big. But oftentimes those symptoms are starting when kids are pretty young. It's also highly impairing. So the obsessive thoughts and the compulsive behaviors that go along with OCD take up a lot of time, a lot of mental energy and emotional energy, and it can really keep kids from living the life that they want to live. So we know that OCD is highly impairing for young people. It gets in the way of their academic performance, their extracurricular activities. It can cause a lot of conflict at home and really strain family relationships, and it can impact peer relationships as well. So we know that OCD not only is prevalent and happens at a young age, but is highly impactful for young kids. And oftentimes it can be hard to find effective treatment. So much so that the average delay between developing OCD symptoms and accessing effective treatment is 17 years. So, from the time that those symptoms first start to the time that a person gets effective treatment, like CBT or exposure and response prevention, can be a long time. So, access to care is a really important issue in supporting young people with OCD. So, having laid that foundation or that background, let's talk a little bit about what OCD is and how to recognize it in kids and teens. So, a very high level overview, obsessive compulsive disorder is defined as a person having obsessions or thoughts that are persistent and recurring and distressing. So, obsessions are typically intrusive thoughts that pop into somebody's head unbidden, unwanted, and cause a lot of distress. And then those are often followed by or paired with compulsions. Compulsions are typically behaviors that you can either see, they can be physical behaviors or they can be mental behaviors, things that a person does in their mind that are repeated over and over again in an attempt to get rid of the distress caused by that obsessive thought. So we have obsessions, which are those persistent, recurrent, intrusive thoughts, images, or impulses, and then compulsions that are the repetitive behaviors or internal mental acts that are done as a way of trying to get rid of the distress or anxiety caused by the obsessive thought. And these two things go hand in hand. And I'll talk a little bit about each of them and how to spot them. But first, what I like to talk about is how those obsessions and compulsions are tied together to create this reinforcing cycle of OCD. So, for a person who's experiencing OCD, this cycle will start by them having an intrusive obsessive thought. And let me just note here for a second for everybody in the audience that obsessive, intrusive thoughts are not unusual. Everybody experiences them. So I think research said somewhere around 95 or 97% of people who've been studied in these research studies reported having at least one intrusive thought at some point in time. And so you might think about what this looks like for you. For some people, this is like driving over a bridge and you look over the side and your brain goes, what if my car just swerved off the side? Or what if I swerved my car off the side of this bridge? What would happen? And then usually our brains go, ugh, that's a weird thought. And we turn up the radio and we keep driving, right? But everybody has those thoughts that sometimes pop into our head, the what ifs, the what if something bad happened that's out of my control. And we're usually able to say, that was a strange thought, and then just keep going with our day. For people with OCD, when that intrusive thought pops into their head, their brain gets stuck on it. And their brain says, whoa, why am I having this thought? What does that mean about me? Does it mean that I want to do this, or that I could do this, or that I might one day lose control and this will happen? And how do I stop that from happening? Does it mean that I'm a bad person? Does it mean that I want to die? I think I want to live, but now I'm not sure. And so you can see how it starts with one intrusive thought that we all experience. But for people vulnerable to OCD, their brain gets stuck on that thought and starts asking more and more questions about what it is, what it means, why it's happening, and how to prevent it. So, with OCD, this cycle starts with an intrusive obsessive thought. And that thought, because their brain gets stuck on it, triggers a lot of anxiety, fear. Sometimes it's disgust, sometimes it's shame or embarrassment, but it triggers a lot of distress and discomfort. And the way that a person with OCD gets rid of that distress is by doing a compulsion to make sure that the bad thing doesn't happen. So it might be that maybe a person has that intrusive thought when they go over a bridge, they're compulsively checking where their car is close to the line as they go over the bridge. Or maybe they compulsively avoid any routes that go over a bridge, or perhaps they stop avoiding driving at all so that they don't have to put themselves in a situation that feels like they could or might lose control. And by doing that compulsion, they feel better in the short term, right? As long as I can check and make sure that my car is on the line and not straying over the line, then I know that I'm safe. I'm not going over. This thought doesn't mean anything. I'm okay. And so in the moment, that distress comes down. But the problem with this cycle is that that process of doing the compulsion actually ends up strengthening OCD in the long term. Because now my brain has learned that the only way I was able to keep myself safe when I had that scary thought was by doing this compulsion. And so the next time I have that scary thought, I'm going to have to do this compulsion again to make sure that I can stay safe. So, what we see in this cycle of OCD is that a person has an intrusive, obsessive thought. It causes distress and anxiety. In order to relieve that distress and anxiety, a person does a compulsion, which helps them feel better in the moment. But in the long term, it actually makes OCD stronger and it makes them more likely that they're going to have that intrusive, obsessive thought again. And so that's how this cycle increases anxiety and OCD over time. So keep that in mind because now we'll be talking specifically about what obsessions are and what compulsions are, and you'll start to see that connection between the two as it fills into this cycle. And before we jump to the specifics of obsessions and compulsions, I like to just first of all acknowledge that OCD is more than just hand washing. I think a lot of times there's some stereotypes or misperceptions around OCD and how it's portrayed in movies and the media. So I think it's important to acknowledge that OCD has a number of different themes, and I'll talk about just a handful here, but recognize also that this is just a small portion of what OCD can look like. And certainly part of OCD does involve contamination. It is a common OCD theme. So it is hand washing, but it's not just hand washing. With contamination, a lot of times people with OCD have an intense fear that they're going to touch something that's contaminated or has germs from somebody else or has dirt from somewhere else that then is going to lead to them getting sick or is going to lead to them contaminating somebody else, like a loved one, and get them sick. So a person might be afraid that if they touch a doorknob that somebody else with COVID touched, they're going to get COVID, or maybe they're going to give their mom a hug and give their mom COVID, and maybe she's immunocompromised, and that's going to really impact her health. So you'll see as I talk through these themes that there's the immediate theme, the immediate fear, and then oftentimes a really worst case scenario feared outcome that those are tied to. So with contamination, it's often about touching something or being in a place that gets you sick or can get somebody else sick. Harm OCD is also a really common theme, and this is oftentimes an intense fear that a person is going to lose control or do something accidentally or on purpose that's going to either hurt somebody else or hurt themselves. And oftentimes, this feels really counter to what they want to do, but they're worried that one day they might lose control or go crazy or have some sort of switch that's flipped that leads them to do something that hurts someone that they love or that hurts themselves. Religious OCD, sometimes called scrupulosity OCD, presents as an intense fear of doing something that offends God or is immoral or is against a specific religion, oftentimes with those feared consequences of um, either being a bad person, being an immoral person, committing a sin, or going to hell, or having someone that you love go to hell. That's another common OCD theme that we see. Sexual orientation is another common OCD theme that we see. Sometimes I'll see this as gender identity OCD as well. And this is tricky because for kids and teens, it is normal and developmentally appropriate to think about and explore sexual orientation and gender identity. With OCD, some of the distinguishing features can be that it's oftentimes about not how you're feeling right now, but a fear that one day you might wake up and realize that you've actually been a different sexual orientation all along and never knew it, or that you've actually been a different gender all along and never knew it, and then are going to have to break up with your romantic partner, or your whole life will have been lived as a lie, or you'll regret everything that happened in the past. So there's often a component to it of, I'm not wondering if I am or I'm not. I'm worried that one day something might suddenly change. And then the way that I've been living is not true, or I'll have to change the way that I'm living. And so this is tricky to tease apart in that developmental age of those oftentimes teenage years. But that's one way that OCD commonly presents. And I mention it here because I think it's important to think about the different ways that OCD can pop up for kids and teens. We're starting to see more and more existential OCD. So this is where OCD presents with a fear of the fact that we might be living in a simulation, or I might be living in virtual reality or a video game or multiverse. This idea that I'm not sure that the things around me are real or that I am real. And what does that mean about my life and what I'm doing and who I am? That's a really common one. And then oftentimes another common theme is just right OCD. And this is tied less to fears and uncertainty and more about something just feeling off in your body. So for some people, it could be maybe they need to do a certain behavior or action until that action feels just right. Or maybe they're bumped on one side of their body and their body feels unbalanced. They need to correct for it by bumping or doing a compulsion on the other side of their body. So that can be another really common presentation that looks at then results in compulsions like evening out or needing to do something over and over again until it feels just right. So again, I share these just as a snapshot of some of the common ways that OCD can present. There are many, many other ways that OCD can present, but I think it's helpful to think about how it looks different oftentimes than how it's presented in movies and media and can really pop up in a lot of different areas. And oftentimes the way that you can tell that it's OCD is because there's an intense fear of something bad happening to yourself or someone that you love that feels out of your control. And then the compulsion is a repetitive behavior or action to try and regain control, regain certainty that a bad thing is not going to happen. So, to get more specific into obsessions, we talked before about how they're recurrent, intrusive thoughts, images, or impulses. And oftentimes they present as these what if worries. So you might have heard me saying those while I was talking through the OCD themes, and I'll give you some examples of obsessions in just a minute. But what if I touch something that was contaminated? What if I do something that gets my mom sick? What if one day I accidentally hurt myself or hurt somebody else? What if I read something, but I didn't read it completely and I didn't understand it, and now my knowledge is not what it's supposed to be? So it's these what if thoughts that pop up and then are often connected to these possible worst case scenarios. So, what if I didn't wash my hands well enough and I actually contracted something like hepatitis and get really sick and have to go to the hospital? Or what if I'm not real and nothing that I'm doing is meaningful and I have no actual control over my life? So these what if worries, usually about the present moment, but that are tied to these really scary worst case scenarios. And then what our brain does when we're faced with this uncertainty or this doubt that feels really uncomfortable is tries to find certainty or guarantees. And that's where the compulsions come in. Compulsions are oftentimes a way of trying to get certainty and make sure that bad things don't happen. Because our brain says, what if a bad thing happens? And then it says, well, if you do this thing, then it won't happen. You'll be fine. And that's where the compulsions come in. Obsessions can also be that feeling that I talked about with just right OCD, where something feels off or different or not quite right in your body, and then having to do something to make it sort of feel right or balanced again. So, broadly, this is what obsessions can look like. And more specifically, there are those what if thoughts that you heard me saying, but just to show you what they can look like. With contamination OCD, it can be things like, what if that doorknob was dirty? What if I touch something that's going to make my mom sick? With harm OCD, it can be things like, what if I lose control and hurt my dad? What if I accidentally miscounted my pills and took too many? What if I wake up tomorrow and feel suicidal and want to hurt myself or kill myself? With religious or scrupulosity OCD, what if I sinned? What if I'm going to hell? What if I live my life in purgatory? What if I'm an immoral person? With existential OCD, what if I'm living in a simulation? What if none of this is real? And many, many other types of obsessions. What if I forgot something important that I just read? What if I forgot to lock the door at home? What if I left the stove on and didn't realize it? What if I left the lights on and that starts an electrical fire and my house burns down? Sometimes people will hit a bump in the road and they'll say, what if that wasn't a bump? What if I just ran over someone's pet? Or what if I ran over someone I need to go back and check? So there's a lot of ways that these what if thoughts can pop up. And they do tend to fall in themes. People can have more than one theme of OCD, but oftentimes we'll try and identify the one that's getting most in their way and focus on that one first in treatment. Like obsessions, compulsions can also take many forms. So we talked about how compulsions are those repeated rituals or behaviors that a person does. as a way of trying to get rid of the distress caused by the obsessive thought. And oftentimes that distress is tied to uncertainty or doubt. And so the compulsion is a way of trying to make sure, right? So it can be things like checking, of like, I'm checking my stove to make sure I didn't accidentally leave it on, or I'm checking the door to make sure it's locked, or I'm checking that all the lights are off to make sure I don't cause an electrical fire. It can also be touching or tapping, oftentimes until it feels just right, or maybe until I reach a certain number that feels good and not bad. It can be cleaning and washing over and over again or for a long period of time, redoing or repeating certain words or actions like rereading or rewriting until things look just right, or retyping until the wording is just right. It can also be things like counting. There can be good numbers and bad numbers. People will sometimes count how many steps they take, count how many steps they take on the stairs. They'll make sure that they end on an even number or end on an odd number, depending on what feels good or what doesn't feel good. They could be things like ordering and arranging, asking for reassurance from loved ones like parents, walking or stepping in a certain way. So this can be things like having to always start with your right foot, or always start with your left foot, or never step on cracks, or always go down the stairs in a certain way. And also avoiding situations where something bad may occur. We'll often talk about the cycle of anxiety and avoidance as going hand in hand. And with OCD, it's obsessions and compulsions going hand in hand, but people can compulsively avoid something as a way of trying not to trigger those OCD obsessions. So, in the same way that a person might compulsively wash their hands if they've touched something that they think is contaminated, they'll also try to avoid touching things that could be contaminated, like opening doors with their hands or touching money or wearing their clothes after they get home from school. They might have to change into a clean set of clothes. So it can be a number of things that involve avoidance as well as doing specific behaviors. Really important to mention here is that it's not with compulsions, it's not just the behaviors that you see. And this is where OCD can really fly under the radar, because it can also be compulsions that you, as the observer, can't see. Oftentimes, there are mental compulsions that a person is doing in their mind to try and figure out if an obsessive thought is true, or make sure that that obsessive thought is not true, or mentally check or compare or body scan to make sure that things are the way that they're supposed to be. So that could be for someone who's worried that they might have done something that was a sin or that offended God. They might then repeat a prayer over and over again in their head until it feels like they've undone the bad thing that they did. Or if someone's worried that their life might be part of a simulation, they might do a lot of body scanning, of sort of mentally scanning how their body is feeling to say, do I feel real? Do I feel like I exist? Do I feel like I'm in control of my own actions? Or they might do a lot of visual checking around their environment. Does this feel real? Do other people seem like they're acting normally? Have I seen them before? Do they seem like they're living their own independent, free willed life or not? It can also things like picturing specific words, images, or numbers that feel good or right. So I think it's really important to recognize that these mental compulsions oftentimes are a component of OCD, but it's why sometimes OCD can be hard to catch, because if a person's not doing the behavioral compulsions, other people, parents, teachers, siblings, friends can't see it because it's all happening in a person's head, the obsessions and the compulsions. And what that means is that it's taking up a ton of mental time and energy that's still going to keep them from paying attention in class, keep them from being present minded when they're with their friends, create a lot of probably irritability and anxiety at home. So they'll often see the consequences of those obsessions and compulsions, even if they can't tell that the compulsions themselves are happening. So I mentioned that too, because sometimes kids and teens won't even know that they're doing them until you ask. Do you body scan a lot? Are you constantly checking with yourself how you feel internally? Are you constantly comparing yourself to other people or checking how other people are acting? And once you name it, they'll say, oh, yeah, I do that all the time. But they may not even realize it themselves. Okay, so keeping in mind examples of obsessions, examples of compulsions, I want to talk quickly about a patient that we saw here at InStride who I'll call Devin, to just give you an idea of what OCD can look like. And then later down the road, we'll talk a little bit about what treatment for Devin looked like as well. So when Devin came to us, he was 15. He loved watching and playing soccer. He lived at home with his dad and two sisters. They had a really close-knit family, and he had a lot of friends. He was very social, very extroverted. And he was a strong student traditionally, but when he started high school, he started falling behind in school. And folks weren't sure why. They thought maybe it was anxiety or worries, but they weren't really sure. And the pediatrician also noticed at his most recent physical that he wasn't keeping up with his growth curve. He was starting to lose weight. So they suspected some kind of anxiety and they brought him to InStride. And as we did the clinical evaluation with him, we realized that actually, yes, there's some anxiety, but really this is OCD. And the reason why we were able to identify OCD was a couple of things. He mentioned that part of the reason why he was falling behind in class was because it was taking him forever to complete his schoolwork at home and his schoolwork in class. And that was because he had to reread paragraphs and pages multiple times because he was having obsessive intrusive thoughts of, what if I missed something? What if I misread it and I got it wrong when I read it? And so I have the wrong information in my mind? Or what if I read it but didn't fully understand it? Or what if I accidentally skipped a few lines and I missed something important in the paragraph? I should just go back and reread it, right? So you can start to see that connection of the obsessive thought of, what if I missed something? What if I didn't get it right? And then the compulsion is, I should just go back and reread it. Of course, the problem for Devin is that he would read it and then he'd get to the end, be worried that he missed something, go back and read it again, and then get to the end, be worried he missed something again, and go back and read it again. So he was reading things, he said 4, 5, 6 times before he was able to move on to the next page. And that was really slowing him down at both at home and doing schoolwork and taking tests at school. And this is a really common presentation of OCD, of needing things to sort of feel complete or making sure I got all of the information before I move on to the next. He also was reporting some things consistent with contamination OCD, but in his case, specifically, dad was contaminated. OCD decided that dad was the one who was contaminated and that he shouldn't be eating any food that dad touched. Dad couldn't set his place at the table. Dad had to prepare separate meals for his sisters, and Devin was primarily eating prepackaged foods that he could just open and eat that dad had not prepared. And so you could see from this, Devin was starting to lose weight because he wasn't eating as much, because he started restricting his diet based on these OCD rules around what he could and couldn't eat. He also had some contamination fears at school as well, so he started to avoid the cafeteria and would try and just not eat at school if he could. And then dad also shared that he was doing things to try and help Devin feel better, like answering reassurance seeking questions and buying special foods for him. And at the same time, we know that these things can oftentimes inadvertently make OCD worse. So dad was doing some things that we call family accommodation, that is meant to make Devin feel better in the moment, but ultimately can actually keep OCD sort of big and strong in the household. And you can see here too how OCD doesn't just boss Devin around; it was bossing the whole household around in terms of how dad did grocery shopping, how dad prepped meals, what Devin could eat. That was causing a lot of strain at home as well. So keep this profile in mind. We'll come back to this after we talk a little bit about treatment. Okay, so how is OCD treated in young people? You all have probably heard this before, but exposure and response prevention, ERP, that is the gold standard, what we know from the research to be the best the best therapy treatment for OCD. And I'll talk more about what that is, but just to give you some data and research up front, ERP is a type of CBT, so it's a type of cognitive behavioral therapy with a big focus on the behavioral piece of CBT. And what we know from the research is that from studies with kids is that it has strong effect sizes, both in terms of kids responding well to treatment, so having a symptom reduction, but also having symptom remission, meaning that for a strong portion of kids, they experience that their symptoms decrease so much that by the end of treatment, they're no longer at a clinical level. Over 70% of patients experience improvement in their symptoms from ERP. And we also know that ERP works equally well when it's delivered in person and when it's delivered via telehealth. So we can do ERP just as well virtually as we can in person. And in fact, sometimes there's some real benefits to doing it virtually. because we have access to the home environment where oftentimes OCD is strongest. A lot of times, especially if there's um, contamination or sort of rituals that people have around their routines in the morning and the evening, it's hard to access those when we're in person in the office, but we can really easily access those when we're virtually with the patient in their home. And then there's some data to suggest that ERP works particularly well for the younger kiddos, suggesting that the earlier you get someone to ERP, the better their outcomes are going to be. So let's talk a little bit about how ERP works. So exposure and response prevention are the two pieces of ERP. What we mean when we say exposure is that are exposing a person to an OCD trigger, to a situation that's going to trigger those obsessive thoughts. And then we are working with them to not engage in the compulsive response. So we are purposefully bringing up the obsession, and we are purposefully not doing the compulsion. And the reason why this works is because this breaks that cycle of OCD. So remember the cycle from before: obsessive thought leading to distress, compulsion happening to relieve the distress, compulsion allowing the person to feel better in the short term, but makes OCD worse in the long term. So here's how ERP changes that cycle. So a person might have an intrusive obsessive thought, they feel distressed, but through treatment, we work with them to not do the compulsion, to resist the urge to engage in that compulsion. So that might mean maybe a person, well, I'll give an example in a minute of what it looked like for Devin. So let me hold off on examples. So I'll walk you through this first. So obsessive thought, triggering distress, and then in treatment, we work to support the patient in resisting that compulsion. What that means is that in the short term, they feel more anxious. And this is sometimes the tricky part for providers, because ERP means putting your patient in a situation where they're going to feel some uncomfortable emotions in your office, which is sometimes feels counter to what we do as therapists. But the idea here is that it's temporary discomfort for long-term benefit. So short-term pain for long-term gain. It's resisting that compulsion. And we're not trying to cause big distress. We're trying to just make it practice approaching situations that are small and gradual, to practice experiencing and tolerating that discomfort and resisting the urge to engage in the compulsion. And by doing so, you might feel more anxious in the short term, but in the long term, OCD gets smaller and a person feels more confident in their ability to manage their own OCD. So how does that work in session? What we will typically do is make a roadmap. Some people call this an exposure hierarchy. For the little kids, we'll call it a bravery ladder. Sometimes we'll call it a fear and avoidance hierarchy. But essentially, it's a list. It's a list of situations that are going to trigger obsessive intrusive thoughts based on what a person's OCD looks like for them. So at the beginning of treatment, we'll work on tracking or building awareness of what the obsessions are and what the compulsions are, so that we can map out the situations that we're going to add to this list. And then we'll make a list of distressing situations that will probably trigger OCD, and we'll rank them from easiest to hardest. And we don't start with the hardest. We start with the easiest, right? Think of this as like a training model, like you're weightlifting, right? You're not going to start by lifting 100 pounds. You're going to start maybe by just lifting 2 10-pound weights. 10 pounds honestly feels heavy to me. It's like 2 5-pound weights. And then moving up to 10 pounds, and then moving up to 15, and then eventually maybe the bar, right? Same idea. We're going to start small and work our way up as we build strength in not doing what OCD tells us to do. And we're going to start with the smaller exposures and increase them and move forward with increasing difficulty. And as we do the exposures, we're going to help the patient practice reducing, delaying, or resisting the compulsive urge. So for example, if somebody has contamination OCD, and when they touch something they think might be germy, their compulsion is to wash their hand for 3 minutes. 3 minutes is a long time, right? The CDC recommends 20 seconds to wash your hands. 3 minutes is a much longer period of time. And so what we might do is we might practice approaching germy situations, and then we could either reduce the compulsion. So we could say, this time, instead of 3 minutes, let's try 1 minute, or let's try 30 seconds, so that we're trying to shorten or reduce that compulsion. Or we might delay the compulsion. So we might say, we're going to touch something germy, and then instead of washing your hands right away, let's try waiting 10 minutes with a dirty hand and then washing your hands. So we're giving that person a chance to notice, tolerate that discomfort, hopefully ride the wave and see that it goes up and then it goes down over time, that they can handle it, and then doing the compulsion if they still need to. And then eventually working up to resisting the compulsion entirely. So touching something germy or dirty and not washing their hands at all, maybe until the next time they go to the bathroom. So ERP works by doing an exposure to a situation that's going to cause OCD intrusive thoughts, and then resisting the urge to do the compulsive behavior. And we map out a list, and then in treatment, we work our way up gradually. So here's what this might look like. So imagine Devin, who is working on, for instance, rereading, resisting the urge to reread things. So we might set up an exposure where we're asking Devin to read a page of his history textbook. And maybe we start by reading one page and then turning the page. And once the page is turned, he can't go back. What this is likely to do is trigger an obsessive thought for him of, what if I missed something important? Or what if I didn't read the right things? Or what if I read something and have already forgotten it? So he's going to have the urge to go back and reread the page. But what we're going to do in session is focus on helping him resist the urge to reread, which will either be resisting the urge to turn the page back and reread again, or sometimes we'll actually use a blocker where he'll have like a 3x5 index card and he'll follow down the page so that he can't physically, he blocks the words from going back and reading as he goes further down the page. What this is going to do for Devin in the moment is that he's going to feel more anxious and uncomfortable because he's not able to do that compulsion. But what it also does is creates a really powerful opportunity for learning, where he can learn that he can handle feeling uncomfortable. And he can even understand most of the content when he doesn't reread. So it starts to break down that OCD logic that oftentimes is not logical, and gives him learning that he can handle and tolerate uncomfortable feelings. So that over time, OCD gets smaller and his confidence gets bigger. So this is how ERP starts to break down that cycle of OCD. In addition to ERP, there's some really important considerations that we also keep in mind, specifically when we're treating OCD in young people, in kids, teens, and young adults. And that's the importance of surround sound support. So I think it's really important to acknowledge that when working with kids, it's different from working with adults, because kids oftentimes exist in the context of their surroundings. And their surroundings are their home environment and oftentimes their school environment. And so when we approach working with kids with OCD, we're working with them individually to target the ERP for their specific OCD. We're giving some individual support to the child, but we're also giving a lot of support to the family, to parents and caregivers in particular, to help educate them about what OCD is, what it looks like for their child, how to help support exposures at home between sessions so they have more opportunities for practice, and then also how they can support their child. And I'll talk about some of the things that we advise to parents in just a minute. And then we also focus on supporting the community, in particular, working with the school. And so same thing with the school. Oftentimes, like I said, OCD can fly under the radar. Kids are really good at hiding or masking their compulsions, in part because their compulsions and their obsessions can feel really shame-inducing or embarrassing. And so they try really hard to make sure that other people can't see them. What that means is that then other people can't support them because they don't know that it's happening. And so we also see part of treatment as looping in the school, educating them on OCD if they don't already know what's happening for the student, and then talking about ways that we can all work together to support the student in that academic environment. So I'll talk a little bit about what we advise to parents and what we advise to schools, since I know everybody here is oftentimes probably trying to coordinate with these folks as well, or you might actually be providers who are working in a school setting. So with parents, like I mentioned before, what Devin's dad was doing was some family accommodation, right? Trying to do things that helped Devin feel less distressed in the moment, but inadvertently was making OCD bigger in the long run. And so we'll work with families to identify if and where that's happening. It's almost always happening, so it's more a matter of figuring out where it's happening and when it's happening, so that you can figure out how to reduce it and roll it back. So we're pulling back on family accommodations, and then we're teaching parents language that they can use to validate their child. Oftentimes, parents always are saying things that they want to feel validating. And sometimes for kids with high levels of anxiety and OCD, the things that parents say don't feel validating in the way that parents want them to. And so we'll work with parents to develop language that practices acknowledging and normalizing how a kid is feeling and letting them know that they understand that it's feeling uncomfortable. So that might be things like, it makes sense that you're feeling anxious about going to school because I know you're worried that that there's some things at school that could be embarrassing for you or contaminated to you for you. Or it makes sense that you're having a really hard time with your schoolwork because I know you're worried about not making any mistakes on your schoolwork because you want to make sure you do everything right. And so it's validating those emotions in an authentic way and still encouraging brave behaviors. And for parents, what that can look like is encouraging small steps towards brave behaviors. Sometimes the big goal can feel really scary or overwhelming to kids. And so we'll coach parents to provide encouragement that just focus on the next small step. And then through a series of next small steps, the kid can get to that big goal. We also focus on praising effort in addition to outcome. It's great if the kid is able to meet the goal and do the thing that they were trying to do. And there's oftentimes a lot of things that are worth praising, even if they don't quite meet the goal. So that we can praise effort, we can praise willingness, we can praise motivation and engagement to also help give a kid that boost to keep doing hard things. And then I think this is really important, but validating the emotional experience of parents and helping them know that they're not alone. Caring for a child with anxiety and OCD can feel really isolating. It can feel like everybody else is just going about their day, and then you have this extra thing that you're trying to help your kid with, but that you feel like you're floundering with. And so it's really common for parents to say not only do they feel anxious and worried, but they feel confused and overwhelmed. They might feel frustrated or angry. They might feel guilty or embarrassed. They might feel hopeless or helpless. So just acknowledging the emotions that come along with being a parent, really being a parent to any kid, but also particularly for kids with anxiety and OCD, where the parenting strategies that we recommend are oftentimes counterintuitive. And so helping them find connections with other parents going through something similar or support groups or parent coaching that can help them work on skills and strategies as well. And then some tips for school, just like we do with parents, we help schools learn more about what OCD is and what it looks like in their student, especially if it's appearing in a way that either maybe they're not used to seeing or that looks a little bit different. So we provide some psychoeducation. And then we might think about ways that OCD is getting in the way at school and how we can set up exposures in the school setting for brave practice of experiencing obsessive thoughts and not engaging in those compulsive behaviors in the school setting to continue to have opportunities to work on OCD. And then similarly with parents, practicing praising brave efforts, and then to the extent possible, recognizing that schools oftentimes are doing a ton with very limited resources, but to the extent possible, collaborating with outside care providers as well for that support, which can be really helpful to just clarify who's covering what and how can we support each other to really help support this patient and this student. So let's take Devin as an example. I'll talk a little bit about what his treatment looked like. And you all already had a bit of a preview, right? He did some completeness exposures, some rereading exposures with us, where he would practice reading at a time limit and then stopping after 5 minutes and not reading anymore and not rereading. And we also worked on some of those contamination exposures as well. So remember that OCD made up some rules that dad was contaminated and that Devin couldn't touch things that dad had touched or eat things that dad had prepared. And so we worked on things like eating in session, eating things that dad had made in session, using shared condiments so that all the family, so touching things that dad had touched in the refrigerator, dad making meals for him, setting his place at the table, and then also trying to resist the urge to ask dad if the food was safe or okay. Because Devin was doing a lot of reassurance seeking from dad. Is this okay to eat? Did you touch this? Are you sure you didn't touch this? Do you think this is safe? Did someone open this before me? And trying to resist the urge to ask those questions. And then in Stride, I'll talk about a little bit about this, but our team includes a therapist, a coach, and a psychiatrist. So medication management was part of Devin's care, starting in SSRI to help with anxiety and OCD. Oftentimes, I think of medication as like giving a kid like helping them up on a step stool to help them get over the fence, right? It gives them a boost. It doesn't do the work for them, but it helps give them a boost to make the work feel a little bit easier. And then we also worked closely with Devin's dad. He was really motivated to participate in treatment and find new ways to support Devin at home. And so dad practiced pulling back on the providing reassurance, right? So when Devin would ask things like, am I okay? Is this food safe? Have you touched this? Dad practiced not responding or not giving OCD the response that it wanted. And dad also started reducing accommodation around some of the things that he was doing with food. So he would cook meals for everybody. He would set the table for everybody. He had previously been separating groceries so that Devin's groceries went in a separate bag and everybody else's groceries went in the other bag. And so he started mixing groceries into the same bag. So again, you can see how OCD was really running everybody's life in the household. And so dad took some steps to try and boss back OCD on his side as well. And with the school, we connected with the counselor, explained how OCD was getting in the way of Devin's schoolwork. And again, this is something it's really hard to catch in the moment, to know that a kid is reading and rereading and rereading. So we helped explain what was happening, and talked about what OCD looked like for Devin, talked about how it was impacting him eating in the cafeteria. And then we worked closely with the school counselor to set up exposures and supports in the school system. So gradually spending more and more time in the cafeteria during lunch, working up to eating in the cafeteria, and then also getting some time estimates from teachers on his assignments of saying, hey, this should take you no more than 30 minutes. I want you to spend 30 minutes on it and then just turn in what you have. And also getting permission for Devin to use a blocker, like a piece of paper, when he read in class to help him practice not rereading in class. So thinking about ways that we can both set Devin up for success at school by giving him some supports, and then also creating opportunities for exposures in the school environment to the extent that the school had resources to do so. And through this, Devin was able to work on his OCD and get back to a place where OCD wasn't running his life anymore. And he was able to catch back up on his classes, get back to soccer with his friends, and live the life that he wanted to live. Okay, so I'm keeping an eye on time. We have about 10 minutes. So I'm going to just go through this super quickly. At InStride, a quick overview of what our treatment looks like and what makes us different. So we provide specialized treatment for anxiety and OCD, meaning we do ERP, we do exposure and response prevention. Exposure therapy is our bread and butter because we know it's the active ingredient of treatment for anxiety and OCD. So that is the hallmark of our program. We also provide, I should have done these one at a time, a 3-person care team. So a therapist, a coach, and a psychiatrist that work together to support your child. Medication management is optional, but is available, and our psychiatrist helps coordinate with the family's pediatrician. We provide that surround sound care support by supporting parents through skills groups, as well as individual parent coaching, and connecting with the pediatrician and the school. And we prioritize fast access to care, recognizing that oftentimes kids need support now. We want to get them in the door as quickly as possible. And so we're able to provide access to care usually in about 2 to 4 weeks, depending on family availability. In terms of how to access our care, so as providers, you all can make referrals right through our website. If you go to our website, there's a Get Started button in the top right-hand corner, and you can click there, and then you can either say, I'm a parent, I'm looking for treatment for myself if you're a young adult, or I'm a referring provider. And you'll answer a few questions, and then as the referring provider, If you provide the contact information for the family, they'll be contacted to schedule a screening, and then scheduled for a diagnostic evaluation, assigned to a care team, and then scheduled to start treatment. I'm gonna hold off on these questions in the interest of time, because I want to make sure we have a chance to jump to some of the questions in the audience as well. But Haley, let me toss it over to you, and then I'll take a look at some of the questions that have come through.
Great. Thank you so much, Taylor, for this great presentation. I know this last slide up, but if you have any questions and would like to contact your local territory manager or learn any more about InStride, you can email us at either providersupport@instride.health or even just info@instride.health or call us. Our website also has lots of information about our treatment program and what we do. And then you can follow us on Instagram where one of our clinicians posts great videos and does some really great resources around supporting parents of kids with anxiety or OCD. So Taylor, I'll hand it back to you to help answer any of the Q&A questions.
Awesome. Yeah, and thank you all so much for your questions. These are some really great questions. I'm gonna sort of like hop around a little bit and pick and choose, but some of them are about OCD in general, and then some of them are about resources, and I'll try and hit both. One question was, can you see a mix of all of these different themes occurring at once? And the answer is yes, absolutely. Oftentimes, oh, thanks. Haley marked it. That's amazing. um, Oftentimes it's not all of them. I think there's can be dozens of different themes. It's not all of them at once, but it can be multiple at once for sure. And they can sort of interact. One of you asked about what's a good resource for assessing OCD, and there are a couple. One that we really like a lot is the SciBox, which is, can I remember the acronym? The acronym is CYBOCS, which is, I believe, the Child Yale Brown Obsessive Compulsive Scale. And that's a really excellent scale because it starts by going over all the different areas of OCD and all the different compulsions to really get a complete sense of what's happening for your patient. And then it goes into some questions of, how much time are you spending doing these things? How hard is it to control? How much do you try and resist doing these things? How much do these obsessions feel true versus not true? So it goes into some of the questions around how much time it's taking, how distressing and impactful it is in your life. So the SciBox is great. Also the Docs, which is DOCS. That's a free self-administered questionnaire online that hits on some of the most common OCD themes. I think it stands for Dimensional Obsessive Compulsive Scale. And so that's a great one as well, just to get a sense of where your patient's symptoms might be. We had one great question about harm OCD. And it says, how can we as clinicians support clients that struggle with POCD? It is a very taboo topic. So what does ERP typically look like? And how do we provide clients with support without unintentionally reinforcing their anxiety of the possibility of snapping and becoming a pedophile? So it's a great question. And I want to talk about this one because this is a theme of OCD that is very common and doesn't get talked about very often. POCD is pedophilic OCD. And again, think of OCD as like the doubting disease. It is all about what if, and a lot of times it gets stuck on the things that feel scariest and feel most counter to how we see ourselves as a person. So POCD is when a person has really intense fear that they might be or become a pedophile. And so what they'll do is they will start avoiding child-related situations, young kids, sometimes their own kids. This is a really common type of OCD to come up with young mothers who have new babies, and maybe they're vulnerable to OCD. They've had OCD in the past, and then OCD will latch on to the thing that they care about the most, their child, and twist it and make it really scary. And so oftentimes a hallmark of this is that there's a really intense fear of losing control, snapping, becoming a pedophile in the future. So it looks very different from somebody who's actually having pedophilic thoughts. And And with OCD, it's tricky because we're trying to live in that uncertainty. But what some exposures can look like is identifying the things that they're avoiding and gradually approaching those things. Which oftentimes with those kinds of exposures, I'm thinking about news articles, videos, websites that have pictures of kids, like Gap Kids website or like Toys R Us website, where you're going to go and things that you would find in your day-to-day life and gradually approach whatever it is that the patient is avoiding, while you as the clinician are holding the belief that this is OCD. I know because of what I know about you and the diagnosis that I've done that I'm not concerned about you, and OCD is latching onto this, so we have to practice it. We're gonna read articles, we're gonna watch videos, we're gonna look at pictures of approaching things that OCD tells you not to do or to avoid in a way that is safe and legal in order to practice bossing back OCD. It is really tricky. When I first worked with POCD and things like sexual orientation OCD and gender identity OCD, I read Jonathan Grayson's book on, I think it's called Freedom from OCD, Breaking Free of Uncertainty, something like that. Jonathan Grayson, and it is fantastic. And it goes into depth around how you can approach these. It's also written for a person experiencing OCD. So that's also a really great resource if you have a patient, a young adult, or an adult who wants to do some reading on their own. That's a great book as well. I also found it very helpful as a clinician. So I would highly recommend that one. For parents, somebody asked about resources for parents. I really like Ellie Leibowitz's Breaking Free from OCD, or Helping Your Child Break Free from OCD, is a great resource for parents that focus really specifically on how to reduce accommodations at home and how to increase validating emotions and praising effort. And so would highly recommend that one as well. Okay, and I know there's like a lot more questions coming in as I talked about this stuff, but I know we are at time. So let me just see if there's any other ones that we can do some quick answers to.
Taylor, if it's helpful, I see a couple about either parents or patients who are resistant to doing exposures and like how aware are patients of the exposure plans or what that process is, if that makes sense.
Yeah, absolutely. And let me actually flip back here. So those are some of the questions we had here of what if a child is hesitant to try treatment? What if parents don't recognize the problem? And this is tricky. I will say at InStride, one of the ways that we support this is by using our combined care team, where our therapist is making the treatment plan and supporting the parent, and our coach is really the cheerleader for the child and is helping to get them hooked into treatment by really making a strong connection with them and connecting on their interests, their strengths, and their values, and then helping them find ways that working on OCD and doing these hard, scary things is getting them closer to their values and the life that they want to live. And so when we're motivation building, usually for kids who are hesitant to participate in treatment, we're doing two things. One is clarifying their values to understand what's important to them in their life. How is OCD getting in the way of what's important to you in your life? And then how is treatment going to help get you closer to the life that you want to live? Why is it worth going through some of that discomfort in order to reach the long-term gains? And then simultaneously, we're also working with kids and their parents to set up a reward system, especially for kids, say 12 and younger, they're going to be very reward responsive. And so thinking about, listen, we get paid for our work. We want you to get paid for your hard work in therapy too. Let's have you earn points for exposures. Let's have you be able to cash those points in for things that you care about. Which, it takes a lot of tracking and coordination with parents, but can really be a big motivator to get kids hooked into treatment. And then with parents, we're doing lots and lots of psychoeducation. I think OCD can be really confusing. And sometimes we'll talk about it. I'll use, we love metaphors. Sometimes I'll use like a superstition metaphor where, OCD is kind of like a superstition on steroids. And everyone has superstitions, right? Where you think about, well, I try not to walk under ladders. If I have a cat run across my path, a black cat run across my path, I have a second thought about that. OCD says the bad thing really is going to happen. And that's why you really can't do it. So sometimes we'll try and connect those two things to underscore what OCD feels like. And that isn't meant to invalidate the OCD experience in any way. It is just meant to give an example of what OCD can feel like. It can feel like a specific action is going to lead to a really bad outcome, and that feels really scary. So I have to do this compulsion because the consequences are too big to take that risk. Okay, so let me pause there, and maybe we wrap up. But thank you guys all for these wonderful questions. I really appreciate it. And thanks for being here today.
Yeah, thank you all so much. As a reminder, we will send out a recording of this webinar to everyone who registered. So thank you so much for being here and keep an eye out for that email from us. And thank you, Dr. Wilmer, again for your fantastic presentation. Have
Thanks,
a great
everybody.